Okay, I'll just introduce you first, yeah?
Yeah.
I'll let some people. Hi, good evening, afternoon, everyone, and good evening. It's in Australia, it's 8 o'clock, and I have Dr. Tan Sook Pei, was my schoolmate when we were in university in UKM, and then she became my colleague while we were in a hospital in Subang Jaya, and now she's currently practicing in Australia in Victoria. So Dr. Tan is going to speak on chest X-ray, and we hope this session will be interactive because she's going to teach us how to spot the differences on the chest X-ray between a normal and an M. Okay, go ahead, Sook Pei.
Thank you so much, Betty, for the invitation to talk.
I'm so happy.
So happy to be invited as one of your guests. So let me just give you a brief introduction of myself. I'm currently practicing as a radiologist in Victoria, Australia. I work for IMED, and I'm based in Traralgon, about 2 hours east of Melbourne. So just as a start to the topic today, so I'm sure we are very familiar with spot the difference. So this was taken,
kill time sometimes,
from a picture from Reader's Digest. And often for spot the difference, you either find something extra there, which is a piece of sushi there, or something missing, as in the bottom of the image where one piece is gone. So the approach is going to be used to look at the lungs on a chest X-ray, spot the difference. So often you get presented with an X-ray, and if you're lucky, the other side looks normal. And because the lungs, the two sides are mirror images of each other, you can tell when one side is abnormal. And if all else fails, you can always compare it with a normal chest radiograph just to see which side is abnormal and what is abnormal. So to start, we are going to look for either extra things which shouldn't be there, or things which are missing from what should be there. And if it's extra, you will decide whether that extra bit is black or whether that extra bit is white. If it's missing, it's usually collapsed lung, and you will decide which lobe it is. Okay. So let's start. Now, if the extra bit is black, now usually that is air. So it could be a pneumothorax or a bulla. I'll give you some examples. This is an example of a pneumothorax. You can see the outline of the pleura as indicated by the arrows, beyond which there is no lung vascularity. You can see the left lung here is hyperinflated. It is blacker than the normal right lung. So this is a pneumothorax. This is quite an easy spot. The next one is
is easier.
Yeah, this is even more marked. So this one has an element of tension where the mediastinum is starting to get pushed to the normal right side. So this is an emergency. And you can see that the pneumothorax is so big that the collapsed lung is towards the hilum, and it's only that little bit and that little bit at the bottom. So easy. What is this? Can you see which side is abnormal? Again, we're talking about black now. So the black's right side and the normal left side. Yeah. So is this a pneumothorax too? So
yeah, I know it's the right side that's abnormal.
Yeah, very good, Betty.
Anyone? Anyone? Okay, let's see what they say, okay? Come on, guys. Give them some time to just type in the anything at all. Sorry, Ayman, is it? Ayman, you want to say something? Right side. Okay, somebody say a right side bulle.
Very good. Ayman,
yes,
you're ready.
Her name. Okay, let then give her name. Okay, her name is okay, Anit Ayuni Ramli. Well done. Okay, so So how is a bulle different from a pneumothorax?
Just now we had a look at the pleural lining. This one has no pleural lining.
That's
So
right.
that is why this is a bit different. So we do see the loosened right side with no lung vasculature, and you only see sort of some vascularity or some vasculature here near the hilum.
Huh?
And the left side here is normal, where the vasculature goes all the way to the periphery of the lung. And here you get normal lung sort of all the way to the side as well. This is a bulla, and often you find that these patients, the history is quite chronic. It's not an acute presentation. And if you look at the chest X-ray 10 years ago, for example, you would already be able to see either signs of fibrosis or even signs of a bulle. So very good, this is a bulla. So now there are pitfalls. When you look at this, it's not always a pneumothorax and not always a bulla. So in a supine radiograph, a pneumothorax can be quite difficult to diagnose. In this patient who is post-trauma, you can see that there is some contusion of the right lung here. There are fractures of the right ribs here, and there's also subcutaneous emphysema.
Yes,
so the pneumothorax in this patient is really, really very difficult and very discrete, and it is only visible as a thin black line outlining the right hemidiaphragm. You don't see the similar appearance on the left side. Why does this happen? Yeah. So again,
flat.
Yeah. So this is a magnified image of what was there just now, and this is the explanation as to why on a supine radiograph, the pneumothorax doesn't always look as typical as on the erect radiograph. So the air being non-dependent is sort of here on top of the lung at the bottom, and the outline of the hemidiaphragm that we can see to pick up the pneumothorax, a very subtle pneumothorax, is just the black line outlining the hemidiaphragm. So quite subtle, and you may not be able to pick it up at first glance. You may have to have a very high index of suspicion, and you may often resort to CT.
If the fact that the patient had fractured ribs and also this emphysema, is it an indication to look very hard for pneumothorax?
Yes, I think clinically you can often tell that there is reduced entry on the right side. And yeah, if your suspicion is there, you probably should ask for a CT if it changes your management. So again, pneumothorax on the CT in this patient, because it is done dependent on the CT scanner again. So air is on the top, and these are the fractured ribs, and also the subcutaneous emphysema that we saw on the chest X-ray. So now, again, which side is abnormal? We're still talking about black, right? So which side is blacker? Does anyone want to answer?
Okay, let's wait for the reply then. Okay, which side is blacker? Huh? Which side is blacker?
Yeah,
and what's your diagnosis?
We're telling you it's black.
Okay, so most people say the left side. Okay.
That's really good.
Yeah,
good
that's
work.
right. Shaswani, Laik, May, Serena, okay, Margaret all said the left side. So what is the diagnosis do you think it is? Can you write it down, please?
Yes.
See whether we can get it right.
So we're happy. The left side is blacker than the right.
Right.
Is this a pneumothorax?
Okay, let's see what they say. Okay, Anis Afiza thinks that it's a left pneumothorax. Yes. Anyone else? Anyone else? No, no takers. Though, even though they have got a side, right?
Yeah.
But, okay. No, Ji Jun say it's a left lung collapse.
Oh, okay. Right. Yeah. We haven't gone to the collapsed lung yet, but very good. You're very advanced. We can't make it that easy for you to say that it's another pneumothorax because it's black, right? Otherwise, we can't keep you interested. So it's true. The left lung is blacker than the right. And in this patient, if you notice, she has a right breast shadow. but there is no left breast shadow. So often patients with mastectomy can have a blacker side where the mastectomy has been done just because of the thickness of the tissue is less.
I see. Oh, this is a very interesting. Okay.
Yeah,
Okay.
so this is mastectomy. So don't be caught out. Always look. When it's black, make sure that there is no mastectomy. And what about this one? So again, the left lung looks a bit blacker than the right. So is it a pneumothorax? Or what could be the cause of this lung being blacker on the left? Any takers?
Oh, Fiona actually got the answer right. She said that the left breast is missing. Does it change the density of the X-ray? Well done, Fiona. Sorry, I didn't get your message before. Okay, go on. Sorry. So this one,
Betty,
okay. This
Betty, you give her a present, okay?
okay.
Yeah.
Fiona, come and get a present for me. Okay, this one then. Okay, any takers for this one? So it's the left lung again that is darker, blacker.
It is.
And it's over the lower lobe that is blacker.
Oh, okay. So this
Isn't
one, I would have to apologize because the resolution is not as good as the others, but it's right. The left lung is darker than the right. And this is because the positioning of the chest radiograph is oblique. So again, it's related to the thickness of the tissue that the X-ray beam has to traverse in order to produce a picture. So the one that is usually sort of the side that has a thicker tissue will become whiter, and the side that has less thickness of tissue will look a bit black. So don't be caught out by this again.
Okay.
It's just
the heart silhouette also looks like it's towards the right?
Yes. So you can see that the ribs look asymmetrical, and if you have the clavicles on the top, you can see that the clavicles, the medial ends of the clavicles are not equidistant from the sinus process at the back. So you can even see from afar that this is oblique. So be careful again when looking at the lungs when it's an oblique position. What about this one?
So basically what you're trying to say is that the lung may look abnormal, but there may not be any lung pathology.
Yes, that's right.
The chest X-ray may look abnormal, but there's no lung pathology. Always keep that in mind. Okay.
Yeah. So what about this one? What about this one?
Guys, this one? Anyone?
So this one, I just wanted to point out with the arrows that there's this extra line that looked almost like the pleura of the pneumothorax just now.
Okay.
So is this a pneumothorax?
Somebody said Tan Ying Zui said, is it the scapula?
Oh yes, very good. So I can show you the outline of the scapula here. This is the outline of the scapula. So very good.
And Xiao also is very good. She also thinks it's a scapula.
Yeah, so you can see the scapula on this side as well, but this one is not the scapula. This one has sort of gone like that.
Oh, I see. So on the left there is a scapular line that we can see, but this is not
the right as well as the left bilaterally.
Okay.
So very good, but this is not the scapula, and this one was a patient who had a skin fold at the back between the cassette and the chest. So this one is just a skin fold. So not all lines are pleural lines, and it could be artifactual.
Oh, I see. So the skin fold is not like as if he had like say a burn or something. It's just a skin fold.
No. Yeah, because sometimes, often, as we grow older, our skin becomes a bit more lax, and it can actually fold on itself. And this is an elderly patient with a skin fold.
Oh, okay, very interesting.
Yeah, so just be mindful of these things when you look at the chest X-ray. So very good. Now we've finished our black. We're just going to go to the white now, okay?
Okay.
Yeah. So when it's white, we want to see whether it's in the pleura, it's in the interstitium, or whether it's in the airspace, just to make it easier for us. Now, if it's in the pleura and if it's fluid, it's usually dependent. If it's in the interstitium, you decide whether it's centrally in the perihilar region or whether it's peripheral at the lung, near the pleural spaces or at the costophrenic angles. So if it's central in distribution, you would have to think of a few common differential diagnoses, for example, pulmonary edema, and not so common, but also often seen clinically, lymphangitis, carcinomatosis, and also some types of pneumonia. Now
sometimes,
the peripheral
TB can also cause that pneumonitis, that kind of feature, right? TB.
Oh yes, if it's an predominantly interstitial type of pneumonia, it can also look like interstitial opacities rather than airspace. It's possible. So now if it's peripheral, we often talk about Kerley B and Kerley D lines. So Kerley B lines are seen on a PA radiograph or an AP radiograph, and Kerley D lines are similar lines but seen on a lateral radiograph. So they are predominantly peripheral in location. Now, if it's airspace, it's usually a consolidation or a mass. So we'll look at each one of this in turn, okay? We'll start with the pleura first. And again, if it's fluid, we know that it's dependent. This is an erect radiograph, and we can see which side is abnormal again, people.
Okay,
now
come,
we're looking
guys.
at white.
Now we're looking at white. And which side is abnormal? Simple question. Anyone? Everyone? Left. Natia. Okay. Eric Bushaswani. Left lower side, Harris said. Okay, so
Very
Mastura also
good.
said very good. So left is obvious.
Yes.
Abnormal.
Yes,
Okay.
it is. You have an excellent group of people listening up to you today, Betty.
No, they're very good. Okay, at first when we started, all of us were, of course, I was also not sure. And then we have done this about 4 months now. And we are getting more and more interactive. Not that, yeah, so they are very, very interactive now. So somebody has already made kind of a full diagnosis. Somebody said the left pleural effusion, and Annie said left pleural effusion with blunted costophrenic angle. So
that's really good, Annie. And then I'm so glad you mentioned that, because that is the meniscus sign. So most of the time we know that from our science classes, back when we were in secondary school, when you have a fluid on the surface, it usually makes a meniscus. So like that. So this is pleural effusion. So the left pleural effusion, which has obscured the left hemidiaphragm and even part of the left heart border here. So this is at least a moderate pleural effusion. Can anyone tell me what's the cause of this pleural effusion?
okay, so we are also broadcasting live to Facebook, and also so we have also people who mentioned that it was the left side that's abnormal. There's no Hasrin. Hi, no Hasrin. Okay, let's see. What is the cause? Anyone? Okay,
So
metastatic. Okay.
We have a clue for you now. Yeah. So we have the left breast shadow there, but there's an absent right breast shadow. And this patient also has a chemopod inside too. So this is a malignant pleural effusion secondary to metastatic breast cancer. Good work.
Yes, very good. Somebody even actually mentioned mastectomy, and Margaret said metastatic. Okay, Anis Hafiza said exudative or transudative. Now,
we can't tell the difference.
We cannot tell the difference. You need to do you need to send your fluid, your pleural effusion fluid, for examination to tell whether it is actually a exudative or transudative. So when you look at X-rays, those words should not come out. Okay, go on.
So next one now. This is a very interesting one. So again, you can see that there is fluid in the lung because it's dependent. But on top of that, you can also see that this patient has a pneumothorax.
Oh.
So when this happens, the meniscus sign goes missing. So when
then
you have an air fluid level, this can happen to your pleural effusion. No more meniscus. So this is a
Oh,
hydropneumothorax.
so it becomes really flat, like a flat line like that.
Yes, it does. So
Oh, like a horizon.
yes, compared to this one with the meniscus,
Yes.
that one has no meniscus. And this is an important pickup because sometimes the pneumothorax can be very subtle. When you don't see a meniscus in your pleural effusion, you must suspect that there is a hydropneumothorax.
I see. So you must look hard for it.
Yes, so no meniscus means it is an air fluid level.
And most times, why do you have hydropneumothorax? Huh? Also malignancy?
It could be a trauma case where there
okay.
is pneumothorax as well as a pleural effusion or a hemorrhage into the pleural cavity. Sometimes it's after a tap.
Oh, I see. So it's actually iatrogenic.
Yes, it could be. Yeah, so it's just one of the things which can be a complication of your tap. So be careful. So now let's move on to the interstitium, and then we have central and peripheral. So now, this is a very common presentation for a chest radiograph. Any takers? We're talking about interstitium central.
Okay, come on.
This is Betty's favorite.
This is probably the only thing that I can read.
Not after this, so now you can read anything.
Yes, after this, I can be a radiologist.
Yes.
Okay,
definitely.
anyone can, okay, so Serena's noted the pacemaker. Yes, it is a single chamber. Okay, so the pacemaker is into the left ventricle, right ventricle, sorry, go on. Anybody else? How about the lungs?
So in this patient, you note that the heart looks big with the pacemaker in. And just to make it easier, let's put a normal chest radiograph there for us to spot the difference. And if you look at the perihilar region in this patient, you see that it's really, really busy. So lots of interstitial lines and maybe on both sides of the perihilar region. Look at the heart border here. The heart border here is not as well defined as the normal chest radiograph there. It looks a bit fuzzy, and this is the typical appearance of a pulmonary edema. So this is cardiogenic pulmonary edema, a patient in heart failure. Let me show you another one. This is
a typical back wing appearance.
Yes, it is. And this is really severe, as you can see. So again, it is bilateral perihilar interstitial opacities. Later, if it's very severe, it can become confluent and it can even become airspace. You notice the shaggy heart borders because of the interstitial fluid. And we move on to the next one. So this one has no signs of heart failure, but still you can see the perihilar interstitial opacities. The history of this patient is very insidious. This patient has been suffering from cancer for a long time, and this patient has lymphangitis, carcinomatosis. So the X-ray appearance can be similar, but the history is usually very different. So this is not pulmonary edema.
And the heart size here is also the same. It's also not big.
Yeah, sometimes there can be heart failure without cardiomegaly, but yeah, often with the typical case, it is enlarged. What about this one now? This patient came in with fever, and this also has history of immunodeficiency. So this is Pneumocystis, pneumonia. So you can see the presentation is often similar on X-ray. So it's interstitial opacities, perihilar region. This patient even has bilateral upper zone ground glass opacity, some airspace abnormality as well. And the presentation is very different. although on X-ray they can look similar, which is why history is very important.
So this is HIV related?
I don't have that history, but I know
Okay.
that it is immunosuppressed. Yeah. And so this one is, again, very typical just now. And now we're going to look at the peripheral lines. So
Yes.
again, we know from afar this is cardiogenic pulmonary edema. But if you look here at the periphery, you can see these Kerley B lines. I will magnify them for you. So they're often very thin linear opacities, extending all the way to the periphery of the lung. It usually measures 1 to 2 centimeters in length, and it is interstitial fluid. And post-treatment, after a week, everything has disappeared. The perihilar interstitial opacities have resolved, and the Kerley lines have also resolved. So this is consistent with interstitial edema due to heart failure. So now we will move on to airspace, the whiteness in the airspace, which could be consolidation or a mass. And we can't really tell the difference in most cases. I'll show you. So they can also be solitary or multiple. Again, the list of differentials can be variable. So now we're looking for white airspace. So you can tell, most of you will be able to tell. Yeah.
Okay, anyone? White airspace, huh? White airspace. Right.
So you will see lots of this in your clinical practice. This patient presented with cough and fever.
Okay, Annie says it's right lower zone, right?
Good.
And Fiona says it's a right lower lobe pneumonia.
Very good.
Yeah,
Very
we have a
good.
lot of radiologists in the making here.
I know. I'm so happy. So
Okay,
this
so AH also
has,
made the diagnosis of right lobe.
good work, guys. So this patient does have some whiteness here in the right lower zone compared to the left lower zone. And this is right lower lobe pneumonia. And on the lateral radiograph, you can see that is in the posterobasal segment of the right lower lobe. So it's quite difficult to tell which segment on the AP or PA, but on the lateral, you can see that it's localized posteriorly.
Oh.
And what about this one?
Okay. So this one is also the right side.
Good, very good.
Okay. So Serena says it's opacity right lower zone lobe pneumonia. I don't know where she's. Oh no, I think she was talking about the previous one. Okay,
Yeah, it's
anyone
almost sort
for
of
this one?
similar in location, isn't it?
Yeah, that's right. Just more medial to previously.
So again,
now,
when we compare the two sides, you can see the difference.
Okay, so anyone?
No, sorry, I just got the diagnosis out for you.
Yes. Okay, go on. Just tell us about it then.
Yeah. So if you compare this one, this is in the middle lobe. So whereas the other one is in the lower lobe, and you can see that the right heart border here is not as well defined as this one.
Okay.
Can you see the right heart border?
Yes.
Very nice. Whereas this one, the right heart border is really very ill-defined. So this is in the middle lobe rather than in the lower lobe. It's quite difficult to tell on a PA radiograph, but if you look at the lateral, just now we had the consolidation at the bottom here, sitting on the hemidiaphragm, but this one in the middle lobe, it goes sort of more anteriorly. So we have the transverse fissure and the oblique fissure here, and the consolidation is in the middle lobe. Happy?
Oh, from the lateral view, it's so obvious, the fissure.
It is, isn't it? It's really nice.
Really nice.
So the radiologists don't bluff you.
Yes.
What about this one? What about this one, Betty? What do you think? Where do they think it is?
It's in the left lower lobe.
Left lower zone. Very good.
Lower zone.
Yeah, we'll put a normal one here for our viewers to compare. And if you look at the left heart border here, see the left heart border? it is very ill-defined compared to the normal radiograph. So where is this?
Okay, guys. Anyone? Easy peasy for you guys. They need some time to type.
Yeah.
Okay. So Ani said left middle lobe pneumonia. And then Fiona said left lower lobe pneumonia. Serena thinks it's left lower lobe. Serena thinks
Very
it's
good.
left middle lobe. And then Shaswani thinks it's left middle lobe.
Very good. So the lungs are almost symmetrical, but not exactly symmetrical. They are mirror
There's
images.
no left middle, right? There's no left middle lobe,
No.
right?
So there's no left middle lobe, but the counterpart of the middle lobe for the right is the lingular segment of the upper lobe on the left. So, which is why the left heart border is obscured, just like the right middle lobe, but it's the lingular segment consolidation in this patient.
Oh, I see. So lingular, is it a different lobe from the lower lobe, or is
The lingular segment is of the upper lobe.
or it's out of the upper lobe? So actually, the upper lobe is divided into two.
The upper lobe has got four segments. So you have the anterior, the apical-posterior, the superior lingular, and the inferior lingular.
Okay, so this is the inferior lingular?
This is just the lingular. I can't really tell whether it's superior or inferior unless I have the CT.
I see, okay.
But it's usually of no clinical significance to tell whether the consolidation involves only the superior or involves both the superior or inferior lingular. So we move. So this one is an infection, and you can see how well outlined the left heart border is after 6 weeks of treatment. So there, consolidation and resolution.
Okay, beautiful.
And what about this one? So we've seen a lot of infection, haven't we? What about this one? Is
mass?
Where is this? Yeah. Is this in the
left
or right?
Left.
Yes. So we're talking about white and we're talking about airspace. So the left side looks abnormal. And this one even has a sort of like a margin to it compared to the ones that we see before. It looks like it's sort of like all over the place. This one has sort of a margin. And this
so we have some diagnosis here. Hold on.
Oh,
so Serena says it's a left lingular mass. So did Shaswani. Okay.
Yeah.
Umi from the Facebook says that it's a left hilar mass.
Yes. Very good. So because she can't really see the hilum very well, separate from this mass, and lingular segment has to obliterate the left heart border, which this one isn't. So it's not a lingular mass. So let's have a look and see on the CT. So this one turned out to be a cancer. And the reason why this is a left hilar mass, as mentioned, is because it is also infiltrating the left lower lobe pulmonary artery.
So, Umi got it right. Umi says that it's a left hilar mass. Umi, well done.
She's really good. It's in the hilum as well as extending to the lower lobe.
But for a tumor that is aggressive and malignant, the border seems very benign, right?
Yeah, you can't really tell. That's why you can't tell when it's a well-circumscribed mass, it's benign. You can't tell. You can't say.
Oh, I see. Okay.
Yeah. So infection tends to be more sort of diffuse. But having said that, if it's a lung abscess, it can be very well circumscribed. Tumors tend to sort of have a mass appearance, but some tumors, which we will show you later, will look just like an infection. So this one, it's more subtle, but you can see that the left lower zone is whiter compared to the right. And this one is an adenocarcinoma of the lung. So it doesn't have a mass-like appearance as the previous case, but it's still a cancer.
I see. Sook Pei, can you just switch on your video so that we can watch your face while you talk?
If I switch on my video, can you see the slides?
Slides? Oh, of course.
Oh, really? Okay, I'll try.
Oh,
All right then.
oh, no, cannot. Something is
There.
wrong. Oh,
Yeah, I
something
don't think
is
it's
wrong.
gonna work. So
Yeah, what
no,
happened?
no looking at me. Look at the slides.
Okay, but okay, good. Oh, now I can see. Okay, it's working. I can
Oh, it
see you
is?
and the slides. Yeah, that's right.
All right. Okay then. So you will get distracted by my pretty face then.
They were not distracted by mine, so don't be too sure they will be distracted by yours. Okay,
So,
go on.
so this one was the adenocarcinoma that we saw, and this is the CT. Again, this is a lower lobe cancer.
Wow, it looks quite not so dramatic as in the chest X-ray compared to the CT scan, right?
Yes, and because the location of it, it's behind the heart.
Oh, I
So
see. So
part
you
of
don't.
the lungs is behind the heart on the left side. So you have to be very careful. That is one of the hidden areas of a chest X-ray.
Okay.
We'll see more about this when we go to lung collapse, okay?
Okay.
So what about this one? Is this infection? Is this tumor? What do you think?
Okay, guys. Let's see what they say. So, okay, we need some of your diagnosis.
Can we tell at all?
I think it's an infection.
Yeah, so it could be. Very good.
Somebody actually suggested pulmonary TB. Yes, maybe.
Yes, possible. Very good.
And
So,
Lai May thinks that there's a right upper lobe collapse. Oh, and somebody says, Ani says multiple hilar lymphadenopathy.
oh yeah, I think that multiple hilar thing could be the quality of the image that are projected. This is just the pulmonary vessels, but I agree that when the film is like sort of a bit whiter, a bit underpenetrated, it can look like mass, but this is normal. But the abnormality here is a white air space in the right upper zone, and this image is just to show you that the whiteness is not specific. It can be infection, it can be tumor, and it can also be pulmonary hemorrhage or anything else. So if it's white, it just means that it's consolidation or mass. It can be any cause, but the history may help you.
Okay. Oh, very good.
Yeah.
So
we
again
come
and
now
again,
to
please take a good
another
history.
case.
Okay.
Yeah. So this one is a patient with fever. So can you tell where are the abnormal white spots on this radiograph?
Okay, I think, okay, guys, tell where's the abnormal white spot. Okay, Natia thinks it's the upper lobe, left upper lobe. Okay.
Very good. Yes.
But I think it's over the right middle and left upper lobe.
Yes. So multiple spots here.
Yes.
And with a history of fever, our first diagnosis is usually that of an infection. So it could be multifocal pneumonia in this patient. Very good. What about this one?
Oh, this looks like, oh,
Yes.
cannonball.
Very good. Very good,
No,
Betty. Yes.
no, the term didn't come from me. It came from all the rest. Everybody is saying cannonball. I completely forgot that term cannonball, to
I'm
be
so
honest.
impressed with your viewers. You're a clever lot.
Yeah, Umi also
So, yes.
says, oh, yes, almost everyone has now commented.
Yes,
Cannonball.
it is lung metastasis. Again, this is non-specific. Multiple abscesses can also look like this, but with the proper history, usually the diagnosis is obvious. So again, history is very important, guys. When you write a request form for X-ray, remember to write a history. So it helps the radiologist, and it also helps you to narrow down your list of differentials. Otherwise, you get a whole list of things that you have to rule out yourself, which is not very good when it comes to your time management. So now we shall leave behind the extra and we'll go to the missing bit, okay? So we're going to go to the second half of our lecture where we look for missing bits of the lung. So we are going to decide which lobe is missing. Okay?
Okay. Okay,
So
can we go
the
back
lung
to just now the previous X-ray? Yes, just to familiarize. No, the lobes.
Oh, yeah.
Okay, upper lobe, middle. Okay.
Yeah. So the right side has 3 lobes and the left side has 2 lobes.
Yes.
The right upper lobe has 3 segments. The middle lobe has 2 segments, and the lower lobe has 4 segments. 5 segments. Yeah. So a total of 10 on the right side, and then on the left side you have 8 in total, 4 in the upper lobe and 4 in the lower lobe. Alrighty, we go on. So we had already spoken on this one, and so this one is the first one. So can you see which side is abnormal? Is it the right side or the left side?
Okay. So yes, some people have said the right upper lobe. Serena Anis, right upper lobe. Okay, good.
That's great.
Right upper lobe. Ili has said right upper lobe collapse.
Very good. Very good. So now the clues to this is that this one here, that's the transverse fissure, which has gone all the way up here, and it has collapsed into an opacity just to the right side of the trachea. So the right paratracheal stripe, we call it, has thickened.
Okay, what's that term called again? That thickening of the
right paratracheal stripe.
Stripe, huh? And the
stripe.
right the
stripe. So it's usually sort of only this thin. See, on the left side, it's this thin. Yeah, it's become this thick because the lung has collapsed onto this.
And the trachea is also deviated to the right side.
Yes, it is deviated to the right side. That's a very good pickup.
And then the right is the heart is also kind of deviated to the right.
Yes, it is. Although you should check with whether or not this is sort of a properly positioned radiograph. So you see the spinous process here, and the medial ends of the clavicle are not equidistant. So it's slightly oblique. So just be a bit careful about the mediastinal
rotation. Okay.
Yeah.
So this is rotated. Okay.
Slightly rotated.
We cannot. Yeah. The fact that stripe is thickened cannot go wrong. Okay. Now that I see the stripe, I see the collapse even more.
Yes. So it's not always like this, but this is an example of almost a total right upper lobe collapse. So you have the transverse fissure moving up towards this side, and then the hilum itself, the right upper lobe pulmonary artery, which you can see the left upper lobe pulmonary artery here, the right upper lobe pulmonary artery is obscured into this. It's gone into this collapsed lung. You can only see the lower lobe pulmonary artery here. The right hemidiaphragm here is also elevated. It's not so well seen on this one, but we'll see some more. So this is a right upper lobe collapse. It's a very tight upper lobe collapse. This one is a partial upper lobe collapse. You don't see the thickening of the right paratracheal stripe, but you see elevation of the transverse fissure and elevation of the right hemidiaphragm. Again, the right upper lobe pulmonary artery is not very well seen. The lower lobe artery you can still see here. So transverse fissure, pulmonary artery, as well as the raised hemidiaphragm. You can also see the hilum here, the right and the left hilum look like they are at the same level. In a normal chest radiograph, the right hilum is always lower than the left. And I have just put this image here to show you where the transverse fissure is usually located on a PA radiograph. It's not up here, it's here. So right upper lobe collapse, just let us recapitulate, recap on this one. So you have the elevation of the right hilum, elevation of the transverse fissure, as well as obscuration of the right upper lobe pulmonary artery. It may or may not all be present, but these are the signs to look out for. Now this one, what is this one? So we've done the right upper lobe. We usually go to the middle lobe. And again, in this patient, you can see that the right heart border is obscured. So right middle lobe collapse is usually very, very subtle. And when you have a normal radiograph to compare, it's usually easier to spot the difference. So this is a right middle lobe collapse. Again, on a lateral radiograph, it's very easy to see. So again, you have the transverse fissure and the oblique fissure, and the lung has collapsed. So the signs of a right middle lobe collapse would be obscuration of the right heart border. Sometimes there's increased opacity adjacent to the right heart border, which suggests an element of consolidation, and it's easier to see it on a lateral radiograph, as Betty has said. Now, be careful. Not all obscuration of the right heart border is going to be a middle lobe collapse. In this condition, where the patient is born with a depressed sternum, it's Pectus excavatum, the right heart border is often shifted a bit more towards the midline, and you can't really see it very well on a chest radiograph. So this is one thing that you have to be careful about before you diagnose a right middle lobe collapse or a collapse consolidation. Alrighty, what is this?
Okay, come on, guys.
So right side or left side abnormal?
Okay, put in your answer. Okay, Anis is always very fast. Anis has given the diagnosis already. Serena says right lower lobe collapse. Okay, Anis, I think, got the right answer. Satral from Facebook has said gastrocardia, so has Anis. More people have said right lower lobe collapse. I think ET says that it's a right pleural effusion.
Okay, yeah, it can be difficult, isn't it, to see? And I agree with you, the right hemidiaphragm cannot be seen. So it could be a pleural effusion, but there's no meniscus here. So it could be a very small effusion. That is possible too. The other finding is this triangular opacity here in the right lower zone, but the right heart border is preserved. So it's not middle lobe, so it's most likely the lower lobe. And dextrocardia, I think, is because of the mediastinal shift to the right side because of the collapse right lower lobe. Very good. Let's have a look at this one. So that one, the triangular opacity and the preservation of the right heart border. This is a right lower lobe collapse. This is another example of the right lower lobe collapse. Again, the triangular opacity, obscuration of the left hemidiaphragm. And if you look at the pulmonary artery, the right lower lobe pulmonary artery, which could be seen quite well in the previous examples that we saw and can be seen very well here on the left side, is not seen on the right side. So all these are signs of a right lower lobe collapse, retrocardiac triangular opacity, obliteration of the right hemidiaphragm, depression of the right hilum because the lower lobe pulmonary artery has been pulled down and the pulmonary artery itself is not visualized. If there is no involvement of the right middle lobe, the right heart border should be preserved. What about this one?
This is the whole right lung is collapsed.
Right lung? The right lung in this one is normal.
It's
yeah,
it's okay.
Right lung, right lung is normal now.
Okay, guys? Anyone?
So the abnormal side is on the left side. Would you like to guess whether it's upper lobe or
I try my best. There's air under the diaphragm.
Yes, this one is a loop of this is a loop of colon. So sometimes it can be seen up here, and this here is the stomach. So this one has gone quite high in the colon, but yeah, sometimes you can see it in this patient.
So it's not exactly perforated bowel. It's not exactly no. Okay.
No, this is sometimes can be seen. So this is normal. The left hemidiaphragm is elevated though. You can see.
Okay, we have some answers. We have some people coming in. So somebody said it's a left pleural effusion. Sorry, Serena says that. Ani says left middle lobe collapse. Shaswani says a left lower lobe collapse with pleural effusion. Umi says that. Umi says feel like opacity. So
Umi,
left
is it?
upper. Yes.
Yeah.
Umi is actually watching from Facebook. She says it's a view-like opacity. The left upper lobe is collapsed. Yi Ching says it's a left lower lobe collapse. And yeah, so come on.
Yeah. So
All
Umi
doing better than me.
Yeah. Umi gets a prize. You claim it from Becky, okay?
Umi, you're right. Okay.
So when you have a lung that you sort of decide that something is missing. So the left heart border is missing. Yes?
Okay.
So that's not normal. So something is missing here, and we're going to decide whether it's the upper lobe or the lower lobe, because there are only 2 lobes in the left lung. So we said that the thing that borders the left heart just now, left heart border was the lingular segment of the upper lobe. So because the left heart border is missing, so the lingular segment must be involved. So this is more likely upper lobe now, plus the hemidiaphragm is preserved. So if it's the lower lobe, the hemidiaphragm would go, because the lower lobe sits on the hemidiaphragm and it would obscure the hemidiaphragm. So let's have a look at what we can see in this one. So it looks like there are veil-like opacity in the left lung.
Okay, tell us about this veil-like opacity again.
It's like someone putting a veil on. So it's not consolidation, but it just looks as if it's whiter than the left side.
Like somebody put a translucent kind of.
Yes, that's right. That's right. Good.
I see.
Yeah.
So Umi,
you can still see the vessels very well, so it's not gone, but it just looks like it's a bit different, a bit whiter. So we have a missing heart border. We have the veil-like opacity, and here, if I show you later what I mean, the anterior part of the aortic arch is also obscured, and I'll show you why.
Okay,
so this is a normal chest radiograph just to show you the anterior part, the arch coming up. So the arch comes up from here, and then it goes, the ascending aorta, the aortic arch, and then it goes down as the descending thoracic aorta. So this bit here is missing. If you see, you can't really see this bit here. I know it's subtle, I'm sorry, a bit of imagination, but when you go to your wards and you have a look, you see, sometimes you can see it. So that bit here is missing. We'll show you some more where that bit is. So on the lateral radiograph, it's sort of this bit coming down. So that one, because it's in the upper lobe, it's gone. You can't see it. It's obscured. So again, you can
explain see again. Okay, sorry.
No worries. So here, this part of the aortic arch, it's quite difficult to see. You may not see it in everyone, but because it is, when the upper lobe collapses, it collapses in this way. We're going to see a bit more afterwards. So that's why this part of the aortic arch is not seen very well. The descending thoracic aorta, which is where the lower lobe is, can still be seen very well. You can see sort of here, you can see the descending thoracic aorta. The outline is very nice because the lower lobe is not collapsed, but the anterior part of the thoracic, the aortic arch is not seen very well. So it's that bit there. So again, what is this?
Umi, come on. Okay, let's see. Anyone?
Oh, I'm running short of time, Betty. Is it okay?
Sorry?
I'm running short of time. I'm almost up to the hour. Is it okay?
It's okay. It's okay. Is it okay for you?
Yeah, I'm fine.
Okay, fine. So
yeah, okay.
Somebody said the left side. Fiona said left-sided. Okay, sorry. Left upper lobe collapse. Left lower. Left-sided upper lobe collapse. Somebody say esophageal rupture. Somebody say tracheobronchial injury. Hadi Shams from Facebook says it's a lingular collapse.
Yeah.
Okay.
So time for the great reveal.
Okay.
Yeah. So veal-like opacity.
Yes. Okay.
Yes.
Now we can appreciate the veal-like.
Yes, you can.
Yeah.
And you can't really see, you can see the descending thoracic aorta, the outline, very well. Again, the anterior part of the aortic arch cannot be seen. So there is definitely left upper lobe collapse, but the left heart border here is preserved. So the lingular segment is not involved in this left upper lobe collapse. So the other signs, which is not specific for upper lobe collapse, which would be volume loss. So you have the mediastinal shift to the left, the trachea shifted to the left, and also elevation of the hemidiaphragm. So again, this is a left upper lobe collapse. I'll show you on CT how a left upper lobe collapses so that you get the idea. So we're coming from back to front, and you can see the descending thoracic aorta here, which is bordered by the lower lobe, and it's really well outlined. So that's why you don't lose the outline of the descending thoracic aorta. As we come more anteriorly now, we're coming towards the aortic arch, and you can see the left upper lobe is collapsing towards the left anteriorly, upper and anteriorly, and you can see the outline of the aortic arch here is obscured by the collapsed lung. So that's why you can't see that outline there. And it's collapsing medially and superiorly. And here's the anterior bit, and it's still there. And on the sagittal view, that means you sort of cut the patient. I think most of you are familiar with sagittal, right? Are you, longitudinal sort of a midline across the sternum. And you can see that the upper lobe has collapsed anteriorly and superiorly. So that is why you get that veal-like opacity, because there's this thickness of the lung that just causes the lung to appear
like a curtain, like a curtain now.
Yeah, that's right. That's right. So that is why you get the veal-like opacity and the obscuration of whatever that we talked about just now. So really good. So veal-like opacity, obscured aortic arch anteriorly, and the left heart border if the lingular segment is involved, and the left hilum is also drawn upwards because it goes anteriorly and superiorly. Very good. So we only have one lobe now, so it has to be the left lower lobe. And the left lower lobe collapse, the sign would be this triangular opacity. Instead of being on the right side, it's gone to the left side now. And it is also obscuring the left hemidiaphragm wherever it's collapsed. So this side is still there, or maybe partially there, but this side you can't see the outline anymore. And this is left lower lobe collapse. So it's a retrocardiac opacity on the left side. The left hilum, forgot to mention, the left hilum, instead of being higher than the right, has gone down now. So the left hilum has is inferiorly displaced. The left hemidiaphragm is obscured. And now, look at this. There's no outline of the descending thoracic aorta compared to the one just now. Yes. So you can see this one, you can't see. So this one, something is missing. The descending thoracic aorta has gone missing. The left hemidiaphragm has gone missing. So yeah, so these are your signs. So another sort of left lower lobe collapse with an associated pleural effusion. And to show you on a lateral radiograph how a lower lobe collapse looks like. So the upper lobe has gone here. That's where the upper lobe collapses just now. Lower lobe collapses down here. So it will go down there. And how do you tell anyway on this chest radiograph? How do you know it's collapsed? It all looks very, very good, isn't it? There's nothing wrong with this one. But if you compare it to a normal lateral, as we go down the spine, the thoracic spine, the lung should appear blacker and blacker. So it's white on top because of the shoulders and stuff. As we come down, it should become blacker. Look at this one. The whole thing looks as if it's the similar whiteness. That's because there's collapse of the left lower lobe here.
Is this still a veal kind of appearance?
Well, if you like, yes. on a lateral radiograph, but we don't describe it as that
Oh, I see.
classically.
Okay.
Yeah, you just know because on the lateral radiograph, it should be blacker as you go down, and this one doesn't become blacker. So you know that that thing here is actually here.
Okay.
Yeah. So just to show you how they are located, to see the abnormality. And this is an axial CT to show collapse consolidation of the left lower lobe. And there's also mediastinal shift to the left side. So right and left, heart and collapsed lung. And this is the triangular opacity that you see with the left lower lobe collapse, which obscures the left hemidiaphragm. And this is how it collapses. It goes down and behind compared to the upper lobe, which goes up and anterior. All right? So in summary, we're coming to the end of the talk. So we're using a spot the difference approach to look at abnormalities of the lung. It can be used just to help you decide which side is abnormal. So what is extra or what is missing? And then if it's extra and it's black, it's usually air. If it's white, you decide where it is. Is it located in the pleura, the interstitium, or the air space? And if you think something is missing, which lobe of the lung? You decide. So you try and use this approach. We have a quiz. So what is this, everyone?
Okay. Post-SDH evacuation. So SDH is subdural hemorrhage.
Yeah, and then this is an elderly patient post-SDH evacuation, and he was on positive pressure ventilation, but he developed sudden shortness of breath. So is this extra, or is there something missing?
Okay, we will answer your question later, Serena. Okay, keep in mind, how does a bronchogenic cyst look like? We'll talk about it later. We'll just do this quiz first. So Margaret Lau said pneumothorax over the right side. Fiona has said right. Natia has said right heart border is missing. Right heart border is missing. Okay.
So Fiona, you said right-sided pneumothorax, did you?
Yes. Anis Yigme has also said right lung. No, Yigme said right lung collapse. Anis said pneumothorax. And then Yi Ching on Facebook said right-sided pneumothorax.
That's really good. So I think most people think that the abnormality is black. It's extra and it's black on this side. So I'll talk through what it is not afterwards. But yes, this patient has this extra black bit here, which is not present on the left lung. And it has, you can see the vessels going all the way to the periphery of the lung in the upper zone, which is sort of more normal, and in the lower zones, which is sort of more normal. So typically we could call this a bulla, maybe.
Okay.
Yeah, because it just doesn't fit all the criteria of a pneumothorax.
I see.
And yeah, maybe. But if this is a bulla, then we say we want to see the previous radiograph, and it should already be there. It doesn't develop sort of suddenly a bulla most of the time. It doesn't. So anything that is sudden onset is usually pneumothorax rather than a bulla. Bulla is chronic. We talked about that earlier. Why is this not a lung collapse? So we had talked about the lung collapse where you can see the lung collapsing towards the paratracheal stripe, or you can see collapse where your right hemidiaphragm is obscured. So this is not obscured. This is seen very well. The paratracheal side, I know it's not great on this one, but it's there is no opacity sort of coming up towards the apex of the lung. The right heart border is here, although this is not the greatest, but the right heart border is still there. So there's no lung collapse here. So we would want to call this extra black, and it's pneumothorax because of the history, sudden shortness of breath. This is a preoperative chest radiograph. So there was no bulla here. So because of its sudden onset, we think it's a pneumothorax, but this is not the typical pneumothorax. This is a loculated pneumothorax. Just to make it a bit more confusing for you all.
Oh, I see.
So this is a CT chest with a loculated pneumothorax. So it can happen, especially when there's some underlying lung pathology, like fibrosis or whatever. Sometimes the scarring can cause the bits of the lungs to not detach from the pleura. It's more almost like a natural pleural disease due to disease. And you can get a loculated pneumothorax in this way. Not very common, but just to show you that.
Okay, I'm sorry, but for example, if we have a case like this, and then we think that the sudden onset of shortness of breath, and let's say the patient desaturate, how do we do a chest tube for this?
I think you can.
Ultrasound guided?
Clinically, you would be able to sort of look for a very resonant area in the lung, I think. I'm not very sure how they do it, but you can even insert it under a CT guidance.
Okay.
If you're not very sure, yeah. And with the underlying lung looking at normal, I think, yeah, maybe it's not a bad idea to do under CT.
Yes. Oh, I think is that why you see some lung tissue marking over the right upper lobe, because it's low.
Because of this one. Oh, sorry. Yeah,
this one where your arrow is. Yes, because of that one.
Yeah.
Yes.
So these are all adhesions. So that's why the pleura cannot detach. The visceral and the parietal pleura cannot separate to give you a pneumothorax all along. So these are already sort of stuck. So that's why you get a sort of a loculated
pneumothorax. So this part
where
stuck is adhesion is a disease process, lah.
I think it's more like a natural pleural disease, like when there's been previous pleural effusion or pleuritis. Sometimes it can sort of become stuck like that. I'm so sorry. That's okay.
Okay.
So
Are
now this
okay?
one.
Okay.
Next question 2, quiz number 2. What is this?
Okay.
This is actually nothing to do with the lungs.
Yes, there's extra white.
Oh, that one is just the chest of this patient. So this is a young man who's very muscular. So the pec on both sides look like it's very prominent.
Oh, no. Extra white as in, air under the diaphragm.
Extra black?
Oh, extra black. Okay, sorry. Yes, extra black. Sorry, yes. So I got it right, but I got the what? Okay. So yes. So Lionel said perforated gastric ulcer. Anis has said air under the diaphragm.
Very good.
Margaret said air under the diaphragm. Yi Ching says is okay. Yi Ching thinks it's a pneumoperitoneum.
Yes, it is. Very good. It is. Pneumoperitoneum. Very good.
Okay, so pneumoperitoneum means air under the diaphragm. Yes,
that's right. So usually it's a perforated hollow viscus, and you can see the air which is under both hemidiaphragm. You try and separate the stomach from that, because often the stomach looks like a loosened structure just below the diaphragm. So you make sure it's not the stomach. And sometimes a loop of colon can also be located under the hemidiaphragm in a normal situation between the liver and the hemidiaphragm. So this one is definitely not colon, because you cannot see any hostration here. So this is an emergency if the patient hasn't had a recent abdominal surgery. So this is an important pickup on a chest X-ray as well. Great. That's the end of my lecture. Thank you so much for your patience and your attention.
Okay, so we maybe you just want to answer Serena's question.
Oh, yeah.
Yes.
So you want to know how it was a cyst, isn't it? A bronchogenic cyst. How it looks like? How a bronchogenic cyst looks like?
It's very difficult to describe, right? Because you are talking about X-rays now.
Yeah. So so we will decide now. So if there is a bronchogenic cyst in the lung, is it going to be extra, or is it something going to be missing? Anis, what do you think? Do you think when you have a bronchogenic cyst in the lung, is it going to be You're going to see something extra on the chest X-ray, or are you going to see something missing?
Okay. Extra. Serena says extra.
Yeah. So is it going to be black or white?
Is it going to be black or white, Serena?
What does a bronchogenic cyst contain? Fluid?
She thinks
Tissue?
it's white. Yeah, she says
Yeah.
it's white.
Yeah. So you would expect to see a white structure somewhere in the lung because the bronchogenic cyst is usually not inflamed. So the margin would be quite well circumscribed. So you may see a well circumscribed lesion, I think usually round, somewhere in the lung, depending on where it is. And if you look at the margins of whatever we talked about under the missing bit just now, you can tell where is it located.
Okay, Fiona has another question. Fiona asked how do we determine whether the X-ray is rotated or not? Any marker for it? I think we mentioned briefly now. Yeah. Yeah.
So just now we had talked on a PA radiograph. If you look at the medial ends of the clavicles, yeah, you can look at the spinous process of the thoracic spine as well. So they should be equidistant from the tips of the tips of the spinous processes.
Maybe you can close the window now. You're sharing now?
Oh, okay, I'm still sharing. I'll show you the radiograph just to show that one. I'll find one nice one. Oops, I've gone back just now.
Okay.
Okay, maybe this one. So if you look at the medial ends of the clavicle on the left side and the right side, and the spinous process of the thoracic spine, so this distance and this distance should be equal or almost equal, so that you determine rotation. So if they are not equal distance, then yeah, they are a bit rotated. Sometimes you can't get perfect images all the time because, yeah, of patient, sometimes the patient just can't tolerate some positions, or sometimes they're just too ill. So, yeah.
Okay, I have to say, okay, somebody asked how to identify ground glass opacity.
Ground glass opacity would be white on the radiograph.
We had one that is upper lobe.
Yeah, so it could look a bit like the veil-like opacity as well, but with nothing missing.
Okay.
Sometimes it may not be as homogeneous. It can be quite patchy. I'll show you the example we had earlier.
I think it was the lymphangitis, right?
Yeah, so we'll have to sort of go there now. Yeah, I think it's this one. Yeah. So it looks like it's compared to, for example, the left lower zone here, which looks a bit more normal. You can see that there's sort of something there. It looks almost like vessel, but it's too far peripheral, too big. Just, yeah.
It looks like a bottle, a glass bottle that has been
almost like the veil-like opacity.
Yeah, that's right.
Yeah.
I think
so that's
we
would ground glass.
We won't take much of your time because you have not even had dinner yet. It's 9 o'clock in Melbourne. So,
yeah, so
I want to say that this has been really, truly an amazing session, and you are an amazing teacher.
Oh, thank you so much. I'm glad you like it.
Oh my God, you have made things so simplified. And the fact that when you say spot the difference, sounds like a very easy thing, but actually it's changed the way people picture on how to, usually they will say, okay, look at the pleural, look at the diaphragm, look at this. But the fact that when you say spot the difference and you tell us what to spot, it is, it basically changed the way our mindset when we look at an X-ray. And because you are such a great teacher, I'm going to invite you back for more sessions. I love the way you teach. Definitely. I'm so happy that this has been such a great session.
Thank you very much for inviting me. Thank you everyone for your attention. See
And
y'all
this is
again.
as close as you can be to Malaysia for the moment, okay?
Thank
We are all
you.
almost all of us watching here are Malaysians, and this is as close as you can be to Malaysia and Malaysians.
Yeah,
Okay,
I
see
feel
you.
so much closer. Thank you. Bye
Yes, I
bye.
will invite you again. Bye. Love you guys.
Bye bye.
Okay, thank you guys for tuning in. Next week, I think we only have one weekday session, which is actually on behavioral therapy and family therapy. Hope to see you there then. Bye bye.